This explainer is based on the persistent postural perceptual dizziness, a clinician's literature review published by Australian dizziness clinics. We're going to jump right in today, because we're tackling a big one. It's the diagnosis that accounts for 1 in 5 patients with chronic dizziness, but it's missed so often that it can take years, and I mean years, to get it right. Just look at that number, 4 years. That's the average time a patient with what's called persistent postural perceptual dizziness, or PPPD, waits for a correct diagnosis. Think about that. That's 4 years of frustrating, life-altering symptoms, countless investigations that all come back normal, and treatments that just don't work. And we're not talking about some rare zebra diagnosis here. This condition affects up to 1 in every 5 patients who walks into your clinic complaining of chronic dizziness. So the big question for all of us is, how do we close that 4-year diagnostic gap? Well, today, I'm going to give you the key. It's a 3-question fingerprint that lets you detect PPPD in under 60 seconds. So here's our roadmap. First, we'll really get a handle on the scale of the problem. Then, we're going to reframe this whole thing as a software issue, not hardware, and trust me, that's a game changer for you and your patients. After that, we get super practical with that 60-second fingerprint, figure out how to tell it apart from its mimics, and then we'll wrap up with the key takeaways you can use tomorrow. Okay, let's dive into the diagnoses we all miss. Now, the single most important thing to get straight from the outset is that PPPD is a positive diagnosis. It was formally defined by the Bárány Society back in 2017, and this is so crucial because it is not a diagnosis of exclusion. It is definitely not just a bucket you throw patients in when you think their dizziness is caused by anxiety. It has its own specific, internationally agreed-upon criteria. So what's actually going on in the brain to cause this? Well, the best way to think about PPP is as a functional sensory motor disorder. What that really means is the problem isn't with the physical bits and pieces. The structure of the brain or the inner ear is fine. The problem is in the processing. And this right here is the core concept. The software not hardware analogy is just brilliant. It's not only accurate, it's incredibly useful when you're explaining this to patients. You can tell them, look, your hardware, your brain, your inner ear, it's all perfectly fine. But the balance program, the software running on that hardware, has been knocked out of whack. It's been miscalibrated, usually after some kind of acute dizzy spell. It just clicks for them. It destigmatizes the whole thing and helps them understand it's a real physiological issue, not something that's all in their head. This flowchart here maps out exactly how that happens. See, it all starts with some kind of precipitating event. Could be anything from vestibular neuritis, BPV, even a bad panic attack. That event causes an acute disturbance, right? But for some reason, instead of the system just resetting itself like it should, there's a failure of that central recalibration. The brain basically gets stuck in this high alert mode. And that stuck state is kept going by these 3 core mechanisms. First, the person develops this stiff, high-risk way of holding themselves. It's almost like they feel they're constantly walking on a sheet of ice. Second, they become way too dependent on their vision for balance. And third, the brain's threat detection centers go into overdrive, becoming hypervigilant to any and all motion. These 3 things lock the patient into this awful, vicious cycle. So, with all that going on, how on earth do we spot this in a busy clinic? Well, the answer lies in what we're calling the 60-second fingerprint. It's a super fast diagnostic tool that's pulled directly from those formal Bárány Society criteria. So here are the full formal criteria. A, the dizziness or unsteadiness has to be there most days for at least 3 months. B is about the triggers. We'll get to that in a sec. C, there's usually a precipitating event that kicked it all off. D, it's got to be causing significant distress or messing up their life. And E, the symptoms aren't better explained by something else. You need all 5 of these to be met. But the real magic, the absolute key, is criterion B. This is the clinical fingerprint. For every single patient with chronic dizziness, you just have to ask these 3 questions. Number 1, is it worse when you're standing or walking around? Number 2, does your own motion make it worse, or, say, being a passenger in a car? And number 3, do busy visual environments, like a supermarket aisle or scrolling on a computer, make you feel awful? Asking those 3 questions takes less than a minute, and a yes to all 3 is highly diagnostic. And honestly, your patients will practically hand you the diagnosis if you just listen for the language they use. They'll say these exact things. Doc, it feels like I'm walking on a boat. Or supermarket aisles and computer screens are an absolute nightmare. And they will almost always tell you they feel so much better when they can just sit or lie down. These are your breadcrumbs, the massive cues right there in the history. Okay, so you've got a strong suspicion, but of course, making a diagnosis also means being sure about what it's not. So let's quickly run through how to separate PPPD from some of the common things that can look like it.
This table is your cheat sheet. It's incredibly useful. You'll notice right away that PPPD symptoms are pretty much continuous. They're there most of the time. That's totally different from the clear-cut episodic attacks you see in vestibular migraine. But now, I want you to look all the way to the column on the far right, the one that mentions oscillopsia. That is a huge red flag, and we need to talk about why it's so important.
So with that in mind, what is the one single most important red flag that we absolutely cannot afford to miss when we're thinking about PPPD? It's this: oscillopsia. If your patient tells you that their vision bounces, jiggles, or jumbles when they walk, that is a hard stop. That is not PPPD. It points very strongly towards a bilateral vestibular loss, and it means you have to order formal vestibular function testing before you even think about putting a PPPD label on them. And this little decision tree puts it all together for you. It's super practical. Step 1, ask about that bouncing vision, oscillopsia. If they say yes, you've got to think bilateral loss. If no, then ask about discrete attacks, which might point you towards migraine. Then you check for orthostatics. If you've ruled out all of those and the patient has those 3 classic triggers from the fingerprint, you can be incredibly confident in your diagnosis of PPPD. All right, let's wrap this up and bring it all home. Here are the 3 most important takeaways from today, the things you can start doing in your practice right away. Number 1, PPPD is the most common cause of chronic dizziness in patients under 65. Remember, it's a positive diagnosis based on clear criteria, not just a label for anxiety. Number 2, use that 3-exacerbator fingerprint: posture, self-motion, and visual triggers. It's fast, it's easy, and it's powerfully diagnostic. And number 3, the big red flag: oscillopsia on walking is not PPPD. If you hear that, you must test for bilateral vestibular loss. So recognizing the condition is that critical first step. The next obvious question is, okay, what do I do about it? Well, join me for our next explainer, where we're going to dive deep into the evidence-based 3-pillar treatment for PPPD. If you want to explore more on dizziness, vertigo, and imbalance, and get access to some really excellent materials for both clinicians and patients, please head over to australiandizzinessclinics.com. And if you found this useful, please do subscribe and share it with your colleagues. Thanks so much for your time.